I know that the chapter title of Healthcare Informatics sounds like it's a very large and complex topic, but I want to just try to help you understand that it really isn't. What we are really talking about here is just using data that you collect on your patients, whether it's patient-related outcomes, generic or specific, whether it's clinician-related outcomes, things that you record in your records that you are just taking and making it so that you're able to use that data to systematically and comprehensively document patient care, to organize and analyze the clinical data that you've collected, right? And also to be able to answer meaningful questions, questions that mean something to your clinical practice that you would not get otherwise, right? You might assume things are occurring when in fact they're not. You're just making an assumption, right? So the data to wisdom continuum that we're going to talk about later is just another way of using outcomes, of determining your goals and collecting data and analyzing that, and then completing what we call the assessment loop, which is something your book doesn't talk about, but it is called the assessment or the feedback loop. Whatever you learn, you have to implement that into your practice, right? That's where wisdom comes in. Healthcare information today is extremely important. It guides what we do as healthcare professionals, and it determines our competency. It identifies what we are good at and where we need to improve. It helps us better utilize the electronic medical records that we have for our patients to actually use that data rather than just collecting it and letting it sit on a shelf and gather dust, so to speak, or just in case we get sued by a patient, right? That's not what our overall goal is. So here is some information on Chapter 18 and healthcare informatics. According to your book, informatics is the art and science of turning data into information. Well, this whole course is about turning data into information. From research methods and analyzing data to use for evidence-based practice to the basic statistical analysis that you use. That doesn't mean that you're collecting and doing all of the statistics yourself. If you're collecting data in appropriate ways, once that data is entered, you basically have to then go in and determine what you want to do with it. How are you going to, or how do you want to look at it? Are there changes or improvements? Are there trends? Did some things get better? Did some things get worse? Um, are there some things that you can spot, like an increase in some certain type of injury to a specific patient population or to a specific body part? Maybe your team has switched from playing on a natural grass field to a turf field, and you want to know what has that done to injuries. Turning the data that we have into information that we can use to help us make decisions to help guide our practice, so we're more effective and more efficient, is what healthcare informatics is all about. Medical informatics is just a little bit different from healthcare informatics. As we just mentioned, healthcare informatics are used to provide information to help us be more efficient and effective in what we do when taking care of our patients. Medical informatics are information technologies within healthcare systems. So what is your MRI finding? How many positive results is your MRI finding? Imaging studies, x-rays, right? Medical informatics plays into evidence-based practice. How many negative x-rays were taken in an emergency room in a given 5-year period? Okay, that is medical informatics. That helps inform us, and that helps us develop things like the Ottawa rules, the Ottawa ankle rules or Ottawa shoulder rules, and other clinical prediction rules. Healthcare informatics is just broader. They're more broad. Okay, they help us be better patient care deliverers. As I mentioned in the introductory slide, the data to wisdom continuum framework, I mentioned that in the introductory slide, but here it is visually. I think that your book does a very nice job of talking about this as well, but I'm going to try to talk about it in just a little bit different perspective. This is a nice way to view healthcare informatics. It's very common across all healthcare informatics, where you collect the raw numbers, you interpret the data as to what it means, you form a concept so you have knowledge, and then you use that knowledge in the right way to make specific changes. Well, that is actually how we do assessment of anything. For example, if I wanted to assess your learning as a student, I might have a specific goal, that I might have a specific instrument that will help me to measure you all individually. And then over time, I would be able to take that data and determine if you're learning at a given level, at a level that I want you to learn at. And if you're not, what can I do to intervene? How do we know that after we've interpreted that data, what is happening? And then in the end, what are we going to do to reassess to determine if that change has had an impact? This is a linear diagram, but in effect, what you should see is that from the wisdom, there should be an arrow that circles back and comes back up to the data for the process to start over again. Essentially, this is showing that we are never truly done learning, and we are never done reaching higher levels of wisdom, right? Because if we have done all of this in the right way, the data should change. Your learning scores or whatever should improve, and then I can start over again and look at how I can continue to improve those scores and help you become better learners or students, and ultimately reach better levels of knowledge as you are all becoming professional allied healthcare providers. When we talk about you as an athletic trainer, or we talk about you as a clinician, all clinicians should be knowledge workers. Okay, the different roles that we have are data gatherers, so gathering information on our patients and on your practice, information users, knowledge users, and then knowledge builders. So if you look back at the last slide with the data to wisdom continuum, we have a data gatherer, then we have the information user, then we have the knowledge user. So we have used that information to develop knowledge. Now we are going to use that knowledge, and we are going to have the wisdom to build off of that knowledge. These are not separate points here. They really correspond to the points on that data to wisdom continuum. So to be a good data gatherer, what you do has to be routine, systematic, and comprehensive. As comprehensive as you want it, but it needs to be easy enough for you to do. The example here is measuring strength. How will you routinely measure it, and how often, right? At what points in time are you doing the measurements? How are you going to approach this for various clinical impairments? How is that going to differ? If you don't collect the documentation or the information easily and systematically in the same way every time, that information becomes less valuable. It becomes less reliable and less valid. So be a good data gatherer. Use what you've learned throughout this course. Gather all the data that you can, even if you don't plan on publishing it. Who knows? Maybe you'll want to go back at some point and mine that data for a future research study. So now you or someone else, because all this can involve more than one person, has been gathering the data. Now you have to use that information or that data. You have to organize it and interpret that information in some sort of meaningful way. In order for you to be a knowledge user, you have to take that meaningful information and compare it to something that already exists. You have to do something with it to build on that knowledge. You're going to have to compile some clinical data from patients. You're going to have to use it in a way that changes or affects your clinical practice for the better. So now this takes us from the user, and we've collected, organized, and compared that data, and now we have to decide what we're going to do with it. How are we going to use this? All right. We now have to have that wisdom to build upon all of this and to collect more data to determine if what we've done has been useful, and if that wisdom that we now have is making an impact. If it isn't, then we might have to go back to the user and the knowledge user stage to determine if we actually correctly interpreted that information, or if there are other ways in which we can use that knowledge. But this just helps us complete that feedback loop that I mentioned earlier. There are many different types of records. We mainly talk about electronic medical records, and you'll get more information on this in other courses. But what I really want you to understand here is that anyone who is using paper and pencil for their medical records is extremely behind the times. While I was actually going through my undergraduate program, I graduated in 2016. Our head athletic trainer that I was working with would not budge when it came to getting away from paper and pencil record keeping, simply because they just did not want to make that change, even against all of our disagreements. And all of our information showing that electronic health record keeping is much better and much more efficient. Now, an EMR allows the clinician to legally record patient care documentation over the course of the treatment of an injury. And these are what we typically are using in our athletic training rooms, what we use to track injuries as they happen with our patients. An electronic health record is the total healthcare record for an individual patient, and it combines the records of healthcare from not just the athletic training room, but from all entities. So the athletic trainer, the individual's personal physician or their team physician, their physical therapist if they have had one, and so on. These capture the cause and the course of one episode from all of these different entities. Lastly, a personal health record is created and owned by the patient. This is where they can go in and update their information with things like their medications that have changed, or if they've sustained an injury that didn't occur during their sport that they want the healthcare providers to be updated on. But it differs from an EMR and an EHR because it is not a legal record created by a healthcare provider, but rather a comprehensive lifetime record that was created by the patient. This table from your book basically just summarizes what we just went over on that last slide about the differences between EMRs, EHRs, and personal health records. It breaks each one down very well to show each record's overall purpose, their timeline, who owns each one, and who has access to each one, and then also who can interact with each of these records. We absolutely talk about confidentiality all the time, but what exactly is the difference between HIPAA and FERPA? So HIPAA is a federal law that encompasses all patient information. It's not just electronically portable information, it is confidentiality. And the only people that have access to confidential medical information other than the patient are the providers who are directly involved in the patient care. So a quick story about HIPAA. I once had a coworker who used to work for a larger hospital system that actually had a professional football player as a patient. And one of the people that they were working with, because they all had access to the hospital system's medical records, and because that person was a fan of the team that that athlete played for, decided, I'm going to look up this athlete's medical information and see what's going on with them. Well, electronic health records are monitored. You can see who accesses the information and when that information was accessed. And because my colleague's coworker was not directly involved in that athlete's direct care, they were fired. They were fired for breach of HIPAA. Okay, you cannot access information unless you are directly involved in the patient's care. Okay, that's an extreme example, but it applies to everyone. Even if you're working at a high school or in a small clinic, if you're not involved in a patient's care directly, absolutely do not access their information. It's against the law and you will find yourself in a lot of trouble. FERPA, on the other hand, are records that are created within an educational system, so a high school or collegiate or university owned health record system. But the same rules apply for this. You cannot and should not be accessing this information unless you are directly involved with that individual patient's care. Even the parents, right? So oftentimes, like with high schoolers, they're under the age of 18, but even the parents, once that patient turns 18, the parents no longer have the right to access that information without the explicit written consent of the patient. Okay, so confidentiality is extremely important, and being able to understand both HIPAA and FERPA will ensure that you do not breach confidentiality and that you remain legally safe as a healthcare practitioner.